Today I will share with you an incredible blast to the past. What did they think about multiple sclerosis in 1879? This is the earliest publication in a medical journal about multiple sclerosis that I could find indexed on PubMed. This is in the Glasgow Medical Journal, which predates 1879 by a huge margin. And I'm sure there were other publications of some sort about multiple sclerosis, published lectures, that type of thing, but this is the earliest I could find in an actual medical journal indexed on PubMed, and I found this very simply by searching multiple sclerosis on PubMed and changing the display options to reverse order of the date of publication, essentially the opposite of what I would normally do. And by the way, the next oldest publication is 1911, a greater than 30-year gap. And here we can see in modern times, publications about multiple sclerosis occur numerous times every single day, and I look at them quite frequently. And what's amazing about this publication is just seeing how people thought about multiple sclerosis so differently. The incredible attention to detail, even though they didn't necessarily have the clinical experience. A lot of experts at the time maybe only saw 20 people with multiple sclerosis, where someone like me has seen well over 1,000. But they really have a great attention to the clinical exam, and they really were the first doctors looking at the correlation between clinical findings, between symptoms, physical exam findings, and pathology. And they actually knew a little bit more than you would think about the disease. Now keep in mind, this is over 100 years before MRI scans became available in the 1980s. Obviously, there was no known treatment of multiple sclerosis. Obviously, the underlying pathogenesis was not well understood. This is simply a case report by Dr. Joseph Coates, who is a famous early pathologist. When pathologists who look at autopsies and try to correlate clinical symptoms with actual disease pathology first started understanding the underlying mechanisms of disease. But anyway, the title of the article is On a Case of Disseminated Sclerosis of the Brain and Spinal Cord, Multiple Sclerosis. The following case, which occurred in the Western Infirmary while I was temporarily in charge of Dr. Gairdner's wards — Dr. Gairdner is his boss at the time — presents so characteristically most of the symptoms commonly met with in this disease that I have thought it worthy of detailed description. I would not, in the first place, recall the principal points in the pathology of this disease, without which the symptoms can hardly be duly appreciated. In fatal cases, it has been found that gray patches — these are the scars, the sclerosis — are present in the central nervous system, distributed with apparent irregularity in the spinal cord or the brain, or more frequently, in both. So what's unique about multiple sclerosis is that it's a non-continuous disease. If you see someone die of a brain tumor, there would be one tumor spread out perhaps throughout the brain, or you would have a stroke in a certain area. There's something unique about multiple sclerosis in that it's a very disjointed pathology. He goes on, these patches extend into the substance of the portion of nervous tissue concerned, and as the nervous tissue proper is greatly destroyed in them, it is to be presumed that the function of the affected parts is seriously compromised. The patches appear to be produced by chronic inflammation. So even in 1879, they knew this was an inflammatory disease. And the inflammatory process involving the new formation of connective tissue — this is the gliosis or scar tissue — causes a corresponding loss of nerve elements and chiefly of nerve fibers. Charcot remarks — Charcot is the first person to officially describe multiple sclerosis. Charcot remarks, however, that the axis cylinders of the nerve fibers are often preserved to a considerable extent in the gray patches, although the medullary sheath has been destroyed. So the axons, the nerve fiber, is intact, but the myelin sheath is destroyed, and this is the first description of multiple sclerosis as a demyelinating disease. Although the patches appear to be distributed somewhat indiscriminately, they seem in most instances to be present to some extent in the peduncular parts of the brain — the pons, crura, medulla oblongata. In other words, the white matter tracts. A lesion having such great variations in its distribution may be expected to present very variable clinical features, and this is, to a certain extent, the case. There are, however, certain symptoms, one or more of which seem to be present in almost all cases, and by means of which the disease can usually be diagnosed. Now, of course, no one would say that today, particularly in a younger person with relapsing multiple sclerosis. There's no symptom that everyone has, but I think at the time they were diagnosing people with more obvious physical exam findings because they had the disease for a longer period of time and more disability. It was just impossible to make a clinical diagnosis of MS in a 30-year-old after their first instance of optic neuritis or transverse myelitis. Most of our readers are acquainted with the classical description of the disease given by Charcot in the lectures translated by the New Sydenham Society. There is also a very full description given in Erb's work on the diseases of the spinal cord in Ziemson's Encyclopedia. Erb is one of the other early famous neurologists. In describing the case, I shall follow chiefly in the lines of Charcot's lectures. GM, aged 59, was admitted to the Western Infirmary on the 28th of June, 1878, complaining chiefly of loss of power in the legs and to a less extent in the arms. Now, they go on later to say that this is a male, but it's interesting that this is a close to 60-year-old male where we think of multiple sclerosis as primarily a female-dominated disease, about 3-to-1 in most Western countries, and also the average age of symptom onset is approximately 30. So this is a little bit atypical, an older male. Mode of onset. In the present case, this departed from the general rule. About 14 months before admission, he suddenly found that he had lost the power of grasping between the thumb and fingers of the right hand. This loss of power, however, was recovered from on the next day. At the same time, he lost the power of speech for a few hours. But this also rapidly improved, although he never after recovered perfect freedom of utterance. So in modern times, neurologists would often describe symptoms as either being acute, in other words, very sudden onset like a stroke, subacute, evolving over several days to weeks, or chronic, evolving slowly over months to years, and multiple sclerosis relapses tend to be more subacute. I don't think they used that terminology back in the day, and so acute may mean evolving over several days. About a month after this, there was a sudden failure in the power of the legs, also accompanied with an aggravation of the affection of the speech, but not so extreme as in the first attack. The weakness of the legs and difficulty of utterance also gradually became less marked, so there's spontaneous improvement over time, typical of multiple sclerosis relapses. I should also mention that younger people with MS are more likely to have relapsing MS, whereas older people are more likely to have progressive MS, but certainly anyone at any age could have a relapse. But he seems not to have returned to his work. On the 2nd of May, 1878, he had another sudden aggravation of the symptoms, ushered in by a marked trembling. After this, he was quite unable to walk, and the difficulty of utterance again became well marked. Since then, the symptoms have undergone little change according to his own account. So you can see a lot of variability in recovery from attacks, sometimes complete recovery relatively quickly, and sometimes persistent symptoms. Cases of disseminated sclerosis generally begin gradually, there being at first little beyond weakness of the lower limbs. Now, we would think that symptoms of multiple sclerosis, particularly in a younger person, usually don't begin what we would call gradually. We would say they begin subacutely in the form of the relapse and are less likely to be slowly progressive. But here, what I think the author means is that the symptoms are not that severe, generally speaking, early on in the disease. But there are not a few cases on record in which the symptoms develop suddenly and unexpectedly. The remissions noted above are also uncommon, but by no means unprecedented. This is interesting. We would think of remission as relatively common, but again, I think they tended to see people with more long-standing multiple sclerosis with more disability. Tremor. This symptom, although not a very obtrusive one, was very characteristically present in this case. It was noted that while lying in bed, he was quite still, but he himself referred to the frequent occurrence of a shaking movement of the arms. When asked to convey a jug of water to his mouth with the left hand, a marked oscillation or swaying movement was observed, not sufficient to spill the water. There was a minor degree of the same with the right hand. When asked to lift an object with the left hand, he exhibited a similar swaying or tremulous movement, but the object was taken up without any of the irregularities of ataxia. So it's a little bit strange use of the word ataxia. Usually we would use that to describe a gait disorder in modern times. His writing was very shaky and he said was much worse than it used to be. We were unable to procure a specimen of his former penmanship for comparison. And so I love the incredible detail to the physical exam. Not only do they ask the patient to write, they compare it to prior samples of writing so they can see what the difference is. Generally in modern times we're maybe a little bit too busy to be so detailed unless the problem is specifically about writing ability, like someone with handwriting dystonic tremor. When the patient was seated with the head unsupported, there was manifested a peculiar nodding or shaking movement. The nodding was sometimes rhythmic in character, and it was often affected the whole body and gave the patient a very striking appearance as he sat on a chair. So this is probably postural tremor. This disappeared when the head was supported on a pillow. When made to stand up, there was at first considerable tremulousness, and on one occasion this became much exaggerated, causing a swaying of the whole body to such an extent that he would have fallen. This swaying was not occasioned by loss of equilibrium, but apparently by a rhythmic tremor of the muscles. As a rule, he had little difficulty in standing, and when he had attained a position of steadiness, he readily retained it, even with his eyes closed. It is to be remarked concerning these various manifestations of tremor that they occurred only when the patient was making voluntary movements, in this respect differing from those of paralysis agitans, where the tremors are usually constant, or, if intermittent, are present rather when the limbs are at rest and absent during voluntary efforts. In paralysis agitans, also, the head is rarely affected. Now, I'm not familiar with this term paralysis agitans, but it may refer to Parkinson's disease, where tremor tends to be present at rest, dissipate with movement, and it also may be higher in amplitude, like a typical pill-rolling tremor. I'm not exactly sure what they're referring to. Affection of speech. This has been already noted as a very early symptom in this case, and one which was intermittent. When examined while lying in bed, this and the peculiar facial expression were the only striking symptoms. The principal peculiarity in the speech consisted of a certain imperfection in the enunciation, suggestive of slovenliness or slurring over the words. So there are all kinds of different speech disorders that people can have in multiple sclerosis. Some people can have dysarthric speech, as though you have difficulty moving the muscles that produce speech. Some people with multiple sclerosis with lesions in the cerebellum can have what's called scanning speech, which is difficult for me to mimic, but is often described as an incoordination between speaking and breathing. And at this time, they didn't really understand the function of different aspects of the brain, so it was difficult for them to make those correlations. But people with multiple sclerosis can have all kinds of speech disorders, including spastic dysphonia, which Selma Blair was reported to have at one point. It's a little bit unclear what this individual has, but most likely some form of scanning speech. Another marked peculiarity was that he spoke in a monotone, the voice giving a kind of sing-song impression. The voice was also weak and almost childish in its tone. It had been previously remarked that the imperfection of articulation was somewhat like that of general paralysis. There was no aphasia and no paralysis of the tongue. So aphasia would be a true language problem where people have difficulty producing certain words, whereas this is a dysarthric type of speech. It's a mechanical problem rather than a problem with true language. And I think they're looking at the tongue because they know problems with tongue movement can also cause a lingual dysarthria, which this individual did not have. The affection of the speech is a very characteristic symptom in this disease. See, I would never say that. I think most people with multiple sclerosis in modern times have normal speech, and only sometimes do people have forms of dysarthria, but they perceived it very differently. The imperfect articulation and the monotonous singing tone of the voice, compared by some to the intoning of the church litany, have been remarked in the great majority of cases. Again, this is most likely Spanish scanning speech that probably the minority of people with multiple sclerosis have today. Disorders of vision. There is no apparent loss of the power of sight, nor is there any nystagmus. Nystagmus is bouncing eye movements. The only definite fact made out is that at times he has double vision. On questioning, the diplopia, which is a term for double vision, presents with a remarkable analogy to the tremors already described. When he first directs his sight to an object, he sees it double, but as the eyes get steadied to the two images, they merge into one. This affection of vision has been present at intervals throughout the attack, but seems to come and go. Examination with the ophthalmoscope, in which my own observations were confirmed by Dr. Thos Reed, showed in the left eye marked congestion of the disc, the margins of which were undefined, and the vessels curved as if the disc were elevated. In the right eye, there was a slight redness of the disc. Now, this is a little bit unusual. Some people with multiple sclerosis with optic neuritis can have swelling of the optic disc, which seems to be what they're describing, but you would definitely have some kind of visual symptom, generally speaking, if you had active optic neuritis. So this may be a red herring. The affection of vision here was very slight as compared with many recorded cases. So they recognize that vision problems are common in multiple sclerosis. Nystagmus seems to be present in about half of the cases. Amblyopia is not infrequently present. Now, amblyopia in modern terms refers to a loss of visual acuity due to non-use of the eye. So let's say you were a child and you had strabismus that was not corrected surgically, so the two eyes were looking at different images. You may permanently not develop vision in one eye due to lack of development of the corresponding occipital lobe. So it's actually a brain problem. So they use the term amblyopia a little bit differently. I'm not exactly sure what they're referring to. Paralysis. To the patient himself, the loss of power in the legs, and to a less extent in the arms, was perhaps the most striking symptom. He was quite unable to walk by himself, and when assisted, the gait was very suggestive of ataxia. So now they're using the term ataxia in the way that we would use it in 2022. There was not indeed any of the violent kicking or forward jerking of the legs so often seen in ataxia, but he exhibited great uncertainty of movement and a good deal of stamping. In this connection, it was to be noted that sensation was not, so far as could be discovered, in the least affected either in the lower or upper limbs. He appreciated the painful sensation of pricking, he had an exact understanding of the part of the limb touched, and he could tell exactly the position in which any part of his body was placed. So what they're testing here is proprioception. Maybe they would have him close his eyes and move his finger and see how quickly he could tell whether it was going up or down. At least that's how we could test proprioception in modern times. They may not have even had access to modern equipment such as a tuning fork, but certainly they had sharp objects to test sensation. And it's kind of unusual that they say this, because in modern times we would say sensory changes are extremely common in multiple sclerosis, perhaps one of the most common symptoms. He had an exact understanding of the part of the limb touched, and he could tell exactly which position of any part of his body was placed. Hearing was perfectly retained. Indeed, he seemed unduly sensitive to sudden noises. The legs could be moved with great freedom while the patient lay in bed. The arms and hands were also undoubtedly paretic. The grasp being weaker than normal, especially that in the right hand. There were never any spontaneous pains in the legs or arms. The muscles were not wasted to any appreciable extent. And so this quadriparesis, weakness in all four limbs, is something that could occur with cervical transverse myelitis or a lesion in the neck. They also note a lack of atrophy or shrinkage of the muscles, and this is common in central nervous system diseases such as multiple sclerosis, whereas with peripheral nervous system diseases such as Lou Gehrig's disease or peripheral nerve diseases, you can actually see significant atrophy of muscles. These conditions are all perfectly characteristic. The motor paralysis chiefly of the legs without a trace of disordered sensation, either in the form of loss of feeling or spontaneous pains, and the absence of any distinct atrophy of the weakened muscles have been observed in most cases of the disease. Again, in modern times, we would say that pain and sensory changes are relatively common in MS. Vertigo. It is noted that when he turns his head suddenly to either side, but especially to the right, the patient has a sensation of dizziness lasting for a few seconds. It is also noted that on occasion of the second sudden attack already described, he was very dizzy. This symptom, however, was obviously not a very prominent one in this case. Now, of course, multiple sclerosis, especially with brainstem lesions, can cause dizziness and disequilibrium, but this description of turning the head and getting a brief dizziness could occur with a different condition called benign positional paroxysmal vertigo, which is actually caused by calcium deposits in the middle ear. So it's possible this individual could have two different conditions. It's hard to say. A lot of the times I see patients with multiple sclerosis that come with a symptom, but they actually have a separate neurological disease. Maybe they have multiple sclerosis plus peripheral neuropathy or plus benign positional vertigo. Just because you have one thing doesn't mean you don't have a separate thing. It's a very, very common condition. Facial expression. This was very peculiar and could hardly fail to attract notice. The patient presented a vague and uncertain expression or want of expression. The features seemed hanging and deficient in mobility. There appeared to be a certain enfeeblement of the intellect, but this was possibly more apparent than real, as the defective utterance and stolid expression gave an impression of stupidity, which was hardly borne out in conversing with the man. Okay, obviously we wouldn't use this sort of terminology in modern times, so I should have said trigger warning, but I guess that's kind of how they describe possible cognitive issues at the time. And so this description of an abnormal expression is a little bit unusual, not typical of multiple sclerosis. And people with Parkinson's disease, sometimes they can have decreased facial expressions, but that's not very typical in multiple sclerosis. Certainly people with MS can have cognitive changes, and I guess the examiner here is saying it was a little unclear if there was actually a cognitive change or if perhaps they were just perceiving it that way because of changes in facial expressions and the tone of voice and the facial features, that kind of thing. In regarding the symptoms in this case, and in the recorded cases of the same disease, one cannot be struck with the great frequency of two symptoms, namely the tremor and the peculiar affection of speech. Tremor is fairly common in modern MS, but speech changes are perhaps somewhat less common. In looking for an explanation of the pathology of these symptoms, we are met by great difficulties. Charcot points out that the frequency of another prominent symptom, paresis, is explained by the fact that the patches in the cord generally predominate in the anterolateral columns, and he suggests that what at first sight looks a very probable explanation of the tremors. Now it turns out in the anterior or front of the spinal cord you have the gray matter that goes directly to the muscle fibers, and this is less affected in multiple sclerosis. But the lateral columns that contain the lateral corticospinal tracts, which are the motor fibers descending from the brain, are affected in multiple sclerosis but cause weakness, not tremor. And the posterior or back of the cord is more correlated with sensory changes, and they seem to think that that's less common in multiple sclerosis. Tremors are actually more associated with lesions in the cerebellum and in the brainstem, especially the middle cerebellar peduncles, but again, they didn't fully understand the neuroanatomy at that time. It has been already mentioned that the axis cylinders of the nerve fibers, the axons, are to a considerable extent preserved through the patches of sclerosis, but they are denuded of their medullary sheaths, in other words, their myelin, and are able therefore to conduct much less perfectly. So even in 1879, they understood this idea that there was partial injury to the nervous system. They will still conduct, but the conduction will be irregular and uncertain, and this irregularity will manifest itself especially when voluntary impulses are being transmitted. This would account for the tremor by the character of the lesion rather than by its situation. And so they seem to understand there was something different about a demyelinating disease than an infarct or a tumor, even back in 1879. It seems, however, according to some cases referred to by Erb, that tremor is absent in purely spinal cases, or cases which are mainly spinal. So this seems to suggest an understanding that tremor is coming from brain lesions. On the other hand, cases in which there were no patches in the spinal cord have presented the same characteristic tremor. It seems, in fact, to be essential for the production of this symptom that there be patches in the brain, so they do understand. As to the part of the brain which is affected when tremors are present, Erb has studied 22 recent cases with this view and seems inclined to believe that where tremor was present, the peduncular structures, pons, medulla oblongata, crura, etc., were affected, while in the rare cases where tremor was absent, there were no patches in these parts or very small ones. It seems that patches are present in these situations in most cases, and so the characteristic tremor is usually present. Taking Charcot's explanation in conjunction with this one, we may suppose that the patches affecting the motor strands in these peduncular parts will cause an interference with the conduction of impulses of the will and so lead to the tremor. The affection of speech is probably related to the existence of patches in the medulla oblongata and pons, but may also be from higher lesions in the brain. And so that's the end of the case. And I have to say, this was just incredible to read. I'm actually very impressed by what they knew even in 1879. And it's just beautiful to look at this sort of lost art of taking an individual person with the disease, spending a tremendous amount of time with them, and really correlating their findings with the autopsy if they eventually do pass away. And a lot of residents back in the day used to learn a ton from autopsies, and of course we don't do that as often. During my training, we did have a neuropathologist review some cases with us, and we always learned a ton, but it's less and less common in the modern era. And, a lot of things about this description were sort of unimpressive. Obviously, they didn't fully understand the variation in the disease. They tend to oversimplify and overgeneralize, but I have to say, given the technology that they had and the limited clinical experience that they had, because multiple sclerosis was probably a lot less common and a lot less recognized at this time, I was very, very impressed. And this is the foundation. It started with this basic understanding that, okay, multiple sclerosis has different manifestations, but we can see that it's some kind of demyelinating disease, it's some kind of inflammatory disease, and that led to further research and further studies that eventually led to the use of steroids to treat attacks, and later the development of advanced imaging and advanced pathology techniques to further tease out the underlying pathophysiologic mechanisms, which led to specific disease-modifying therapies and other modern interventions in multiple sclerosis. Anyway, I found this very fascinating. I'd be interested to know, were your symptoms similar to this individual's? Do you kind of, resonate with some of it? Were your symptoms a lot different? And what do you think about early neurologists and pathologists like Joseph Coates? And do you have any suggestions for future videos?